Welcome, everyone. My name is Lillian Maron, and I am the Director of Outreach and Education at End of Life Choices, New York. Thank you for joining us for this discussion on voluntarily stopping eating and drinking. Before turning it over to our speaker, I will share a bit about our nonprofit organization. End of Life Choices New York is the leading organization in New York working to improve end-of-life care and expand end-of-life options to ensure a peaceful death. We do this by educating the public and healthcare professionals on end-of-life issues, by pursuing legal and legislative reform to ensure a patient's right to a peaceful death, including implementation and enforcement of advanced directives, pain and symptom management, and legalization of medical aid in dying. We also provide free counseling and support to those preparing advanced directives, caring for a terminally ill loved one, or who are approaching the end of life themselves. Our counseling services will be discussed more during the presentation. So without further ado, I will introduce our speaker, Dr. Judith Schwarz. Judy is the Clinical Director of End of Life Choices New York and was the East Coast Clinical Coordinator for Compassionate Choices. She earned a doctorate in nursing research from New York University and has been a nurse for almost 50 years. She publishes regularly in nursing and palliative care journals. She has counseled hundreds of patients suffering from incurable and progressive or terminal illnesses and their families about end-of-life options. For years, her work is focused on voluntarily stopping eating and drinking as an option to achieve a peaceful, patient-controlled death. More recently, she began responding to requests for assistance from patients diagnosed with an early stage of dementia. With colleagues in other disciplines, she developed the End of Life Choices New York Dementia Directive that has been completed by hundreds of individuals. Judy, I turn it over to you.
Thanks, Lillian. So hello, everybody, and thanks for joining this Zoom meeting. These are the issues that I'm going to be discussing with you today. And the first is, why do people call End of Life Choices New York? The second is, for various reasons, some decisionally capable New Yorkers want information about how to legally hasten their own death. And at this time, the only option there is voluntarily stopping eating and drinking, or VSED, as we say. Then we're going to show a short video of a woman who chose to hasten her death by stopping eating and drinking. And finally, we'll discuss the Dementia Directive, which limits future hand feeding in the event of advanced dementia. We will leave time for questions and answers. End of Life Choices New York works closely, in the patient support program. We work closely with palliative care and hospice clinicians to facilitate good symptom management and timely hospice enrollment. For decisionally capable persons suffering from terminal or incurable and progressive diseases who wish to hasten their death, the only patient-controlled legal New York State option is VSED. With good symptom management and support, this option can provide a peaceful, gentle death. I want you to know, though, even when information about hastening death is not used by people, they are comforted by knowing they have a choice in controlling the timing of their own death. And then, what is VSED? It's important that everybody be on the same page about what this means. Voluntarily stopping eating and drinking is a decision to deliberately hasten death by stopping all oral intake. We're talking about food and fluid here, while the person is still physically able to eat and drink. It is an intentional and voluntary choice by a decisionally capable person who suffers intolerably, and they get to define what that means, from an incurable, progressive, or terminal illness. And the goal of doing so is to hasten their death. This is different from the loss of appetite that often is experienced by dying persons as death nears. And I can tell you it's rarely anybody's first choice, but often there are no good legal options to hasten death. So I think it's also important that we define what a successful VSED outcome is and how is success defined. And this is my definition. A successful outcome is a peaceful death with a minimum of discomfort, which occurs within a predictable period of time, and that can be days or weeks. Not knowing and uncertainty is very, very challenging to deal with. The cause of death is dehydration, not starvation. And VSED is legally available in all states if the person who makes this choice is decisionally capable and makes a voluntarily, i.e. uncoerced, informed and contemporaneous choice. So here are the 4 ingredients that are necessary. They need to be in place for a successful VSED death. The first is a decisionally capable suffering patient who is very determined to hasten death by fasting. That person must understand the process, know what to expect, and have concluded that the burdens of living consistently outweigh the benefits of continued life. And I should say, this option is not for everyone. Nobody can do this for you. You have to take charge yourself. The second ingredient is the need for social and caregiving support. So you need to have family members or close friends who will journey along with you and understand why you've made this choice. The caregiving support ends up usually being 24/7 because you will end up in bed and you need to be well cared for while you are in bed. The third thing that's necessary for success is access to hospice or palliative medical oversight. This cannot be forgotten. It's absolutely crucial. You can't do this alone. You need to have help from caregiving support and hospice or palliative care physicians or clinicians. And the fourth thing that's necessary is all involved with this decision must have patience with the process. So what are the challenges to a peaceful VSED death? For those with a terminal illness, which means the definition of that is some physician's guesstimate that you'll die within the next 6 months. For those folks who are in a terminal state and nearing death, forgoing food usually is not difficult because your appetite is diminished. You're really just not hungry at all. Forgoing fluids can be challenging, there's no doubt about it. But with good basic nursing care, bedside aids, providing good oral care, rinsing and spitting, the fine spray sprayed on the back of your throat, toothbrushing, mouthwash, anything that helps relieve the feeling of a dry mouth will indeed help you tolerate that kind of thing. In addition, the use of small doses of opiates or an anti-anxiety medication will facilitate a sleepy state. The usual length of the fast is 7 to 14 days. The average for people who are terminally ill is about 10 days. If fluids are significantly limited, ideally, you stop all fluids because that's what's crucial here, is stopping all fluids. And if the patient is terminally ill. Often the patient will slip into a coma during the final days of the fast. So it's important to stress that family and caregivers will also need support. As the patient continues to forego fluids, they will go into organ failure, and that's a process that occurs over some time, which can cause the patient to be confused or occasionally agitated or suffer from delirium. Hospice clinicians can and will provide medication to address those symptoms, to relieve those symptoms. The other thing that's very important is before starting a VSED process, the patient, the family members, and the caregivers must discuss how the patient wants their caregivers and family to respond in case the patient asks for or seems to want fluids once they've lost decision-making capacity and they've no doubt then forgotten their plan to hasten their death. So this should be discussed ahead of time, and the patient can say, well, give me little bits to make me more comfortable if I seem to be uncomfortable. Or alternatively, they may say, give me nothing, just give me more medication so that I'm sleepy and I don't experience anything. This is an important discussion that needs to happen before the patient embarks upon this process, because after several days, possibly the end of the first week, patient will not be able to make informed choices. So the goal should be, if you're giving fluids to provide comfort, you provide the least amount of fluid possible to provide comfort, while reminding the patient of what their plan was initially, which was to hasten their death. So there are more challenges when the patient is not terminally ill. For one thing, it can be difficult to obtain palliative medical oversight. Sometimes the primary care physician will order medications and provide that palliative management. And other times, a patient must begin to fast for several days at home before the family or the doctor will contact hospice to say, "Mom's dying and I don't know what to do and I need some help here. Will you come and help us?" And usually hospice will step in then, realizing that the patient is close to death. In the absence of a terminal illness, fasting can be more challenging, and it can last longer, sometimes up to 3 weeks rather than the 10 days. There must be no question, though, that the patient's suffering has become intolerable and the decision to escape is voluntarily made and well informed. So there occasionally are ethical issues that are raised by clinicians and other caregivers who are providing support for somebody who's chosen to stop eating and drinking. Some may question whether providing VSED support is morally equivalent to assisting in a suicide. Somebody who stops eating and drinking is causing their death, and technically speaking, I suppose one could call that suicide. On the other hand, one has dominion over one's own body, and if you decide not to put something in it to hasten your death, that's fine too. It's like any other life-prolonging measure, in my view. So those who believe it's always morally wrong for a person to hasten death may hold that providing information or support for VSED is also immoral, and they get to make that decision. Healthcare professionals are not obliged to provide care they find morally objectionable. However, claims of conscience permit withdrawing from a case, but not abandoning a patient or not providing transfer to somebody who will tell them about options that they're legally able to make. So next, we're going to have a little video that is about this wonderful woman, but let me tell you a little bit about it first. It was made by a daughter, Mary Beth, at the request of her mother, Rosemary. She wanted others, Rosemary wanted others to know how empowering it was to make a choice about when to die. And she wanted others to see what it was like to hasten death by stopping eating and drinking. We've edited this video for this presentation, but you can view it in its entirety by going to our website and downloading it. Rosemary was able to obtain home hospice support due to the assistance of a nurse care manager. This video is about 8 minutes, and then we'll come back to more chat afterwards.
My name is Rosemary Bowen, and this is day 2 of my fast. This fast is going to accomplish for me leaving life on my own terms. I am leaving life with great joy. I cannot tell you how content I am, and I recommend it highly to do it this way. Be in control. Don't let people decide anything about you and keep you doing a lot of procedures that are not going to benefit your health at all. Just get on with it and go.
For the past 20 years, my mother had warned my siblings and me that when she got to the point where she could no longer take care of herself and live independently, that she would hasten her death by fasting. She said that for her, life would not be worth living if she had to rely on caretakers to bathe her, dress her, and take her to the toilet. My mother was fiercely independent. She lived in her own apartment, did her own cooking and cleaning, socialized with lots of dear friends. She was in good health for her age, although osteoporosis had weakened her bones. But then in October of 2018, while she was out eating lunch with friends, she pulled a muscle in her back. At first, the pain was low level. Her doctor gave her pain medication. But over a 3-week period, the pain became so intense that she had difficulty walking. I took her to the emergency room and they did an MRI. My mother was diagnosed with something that is common in elderly women, spinal compression fractures. 2 vertebrae in her spine had collapsed. For my mom, that was it. When she found out that she had spinal compression fractures, she said she was ready to go home and die.
The price of staying alive is having to live without quality and joy. It is a burden to live like this, and the sooner I can be released, the better for me. In the beginning, I had a lot of resistance from my children, but as time has gone by, they have come around to understanding that it is right for me to be leaving soon. I feel really good about my decision. This is day 2, and it really is not that bad.
Day 3 of my fast.
How are you feeling?
Okay, good. Happy.
Are you hungry?
Relieved. No.
Are you thirsty?
No, but you are, Mary Beth. Get out and get something to eat. Well, I'm sitting up here talking to Mary Beth, and I've been just walking down the hall, and now I realize she's taking a picture of me. It seems to me that I am the most photographed dyer you ever saw. So I'm counting on your prayers, and I'll see you in heaven. Okay. Darling, I will. Thank you, Eileen, so very much. Bless you. I love you too. Bye-bye. She's a wonderful person. I love her so much. And I don't think I have to worry about anything, do I?
No, you're day 5 and you've said goodbye to everybody.
Is there, no, but you have to go where you're going. I'm holding you up. Get out the door now.
So, Mommy, you say you're starting to feel different. How are you feeling different? What's different?
I feel less strong, I can tell.
Do you feel weaker?
Yeah, I do. I'm delighted.
And tell me again what day this is. Do you remember? Day what of the fast?
Day 5.
That's right. That's right. That's right. And you're not hungry?
No.
Not thirsty?
Well, I love having what Kate arranged for me so
The
beautifully.
wine.
Yes.
Lunches.
Yeah.
The doctor said your pulse was 122.
Right.
And so he said it was sort of like you're running fast all
Right.
the time.
Right.
And how are you feeling?
I think I feel as if I am breathing harder than before, which makes perfect sense.
Uh-huh. And so what do you do when you feel anxious about, any shortness of breath?
Then I ask for morphine.
And does it help?
Yes.
Good. Night, Mama.
Hi, darling.
How are you feeling?
Well, Mary Beth, considering, I hope I'm ready to go.
Do you have any regrets at all about what you're doing?
Absolutely none.
Uh-huh.
One of my greatest joys in dying is freeing up the family not to be so engrossed in my last act.
Okay, but you know that I would much rather have you live for another year or two.
Oh, God.
No, I do. But I mean, I always thought that the main reason was the independence.
That it's understood that's part of living independence, Mary Beth. It's understood. Anybody who lives without independence, to me, that is not life. It may be for some. It's not for me.
Mm-hmm. So you just did not want to have that sort of slow, debilitating slide into being more and more dependent on other people?
You know that, Mary Beth. You know that very well.
Okay. The school calendar.
I want to know. I have read of the school calendar.
Okay, and when you say the school calendar, do you mean this school calendar?
Yeah,
here?
I want to know. I have no more. No, I have no more. Get rid of it. Where is
You want me
it?
to get rid of it? It's right here, but do you want me to throw it in the trash? No. What do you want me to do with it?
On the desk.
On the desk, okay.
This. No, get rid of it.
Okay.
You know what I mean. I don't want to think about this.
Okay, all right.
Let's talk about who calls us, who calls our call-in number, our patient support number. And usually there are folks with advanced cancer, either a new diagnosis of a widely spread disease that can't be treated, or the return of a previously controlled disease, usually cancer again, or often end-stage ALS, Lou Gehrig's disease. But then around 2016, I began to hear from a new group of patients and family members. Somebody within the family was diagnosed with an early stage of dementia, often Alzheimer's disease. And those with the diagnosis were desperate to avoid the final terminal stages of that disease, which can last for months or years with good care. So let me just give you a few tiny dementia data things here. 6 million Americans now have Alzheimer's disease, and that number is expected to rise to 14 million by 2050. Advanced dementia, including Alzheimer's, is the 6th leading cause of death in the US. And 10% of all people over 65, that's definitely me, have Alzheimer's disease or another dementing disease. And older African Americans are twice as likely to have Alzheimer's as older whites, and older Hispanics are 1.5 times as likely to have Alzheimer's disease as older white folks. Although people can live well for several years with dementia during the early stages, most want to avoid the terminal stages. And there are 7 stages of the declining abilities, and we'll look at that next. These are known as the stages from the Functional Assessment Staging Test, FAST. If you Google that, you can see this yourself. There's a lot of information about this, and this is what neurologists have all agreed upon. There's no going back. People go through these stages at different times and for different amounts of time. But what's important to see here with this slide is up until stages 4 to 5, folks can manage okay. They might need some help. They can't balance their checkbooks anymore, and they might need some help with dressing and that sort of thing. But it really isn't until stage 6, when you begin to get into moderately severe dementia, that folks really, really will need a lot of supervision and assistance with activities of daily living. And that's when we begin to see incontinence and needing help with bathing and dressing and toileting. Stage 7 is definitely advanced or terminal, and that's sadly hallmarked by loss of speech, disability, inability to recognize loved ones. They can't ambulate or sit up without assistance. They cannot feed themselves. And I think most sadly, they can't smile. This terminal stage can last for months to years if the patient is carefully hand-fed. So let me tell you how we came to develop this Dementia Directive. And it came about as a result of requests from folks who were so desperate for some assistance here. And also, there were two West Coast landmark legal cases that focused national attention on issues of assisted oral feeding. Legal and philosophical scholars had begun thinking and writing about advanced directives to limit or stop oral intake when dementia became advanced. The first steps in this direction were taken by our sister organization on the West Coast, End of Life, Washington. Plus, we had our own difficult case and a growing number of New York callers, as I said, with concerns about dementia. So these West Coast cases, the first one was Margot Bentley of Vancouver, BC, Canada. She was a retired nurse and she had completed a living will that she revised frequently. But the last one that she sent to her daughters, she wrote that she was refusing nourishment and liquids if suffering from extreme mental disability. And then when she came back to Vancouver, she developed Alzheimer's. And for 17 years, she was spoon-fed in a nursing home for years, despite her family's efforts and multiple unsuccessful efforts to get judges to honor her directive. They took a video of nursing aides, shoving a spoon in her mouth, and eventually if they put some chocolate on it, sometimes she'd open her mouth. And so the judge looked at that and said, oh, she changed her mind, as if she had a mind that could still be changed. She finally died in 2015 at age 83. The second case involved Nora Harris. She was a research librarian in Oregon who developed early onset Alzheimer's at age 56, which is a terrible thing because it means that the slope to dying is much steeper than it usually is in Alzheimer's disease. She completed an advanced directive after she knew her diagnosis, in which she wrote she wanted to prevent her life from being prolonged when the disease got worse. However, sadly, she made no mention of her wishes about hand feeding. And again, she was spoon-fed for years in the nursing home. And the nursing home clinicians were not trying to be malevolent. They said, so long as she's opening her mouth and cooperating in feeding, we have to keep feeding her. Her husband went to court twice to try to get them to stop the feedings. And the judge, although he might have been sympathetic, said the written directive was not specific enough. It didn't mention hand feeding. So finally, again, she died in 2017 at age 64. And let me tell you about our challenging case that we had in New York that really helped focus my attention. So I got a call from Hannah's daughter, and she asked me to come and see her mother because she needed help trying to figure out whether there was anything she could do to help her mom escape, as it were. We stood at the foot of Hannah's bed, and her daughter asked, "What did I do wrong?" I watched Hannah being fed by a couple of aides. Before the Alzheimer's diagnosis, if she had Alzheimer's, I don't know exactly what her diagnosis was. Hannah and her daughter went and met with a family physician, a family attorney, I beg your pardon, because her husband had died, and so she needed to have a new healthcare agent, and she obviously wanted that to be her daughter. In those days, this was many, many years ago, there was no consideration of future dementia or hand feeding. What she did refuse was aggressive, life-prolonging treatment. And she said, furthermore, she didn't want to waste money. She hated wasting money. And she didn't want to be cared for in a way that was going to be using her estate. Hannah is now, when I saw her, was 99. And for 16 years earlier, her diagnosis was Alzheimer's, as I say, or some other dementia. She'd been in diapers for 9 years in a hospital bed in her living room. She no longer speaks or moves purposely. She does not recognize her only child or her longtime caregivers. Nobody knew then to ask about hand feeding, and many still don't. Hannah is spoon-fed, or was spoon-fed, 3 times a day by very patient aides, and each meal takes more than an hour to complete. She reflexively opens her mouth when a spoon is brought to its side, like a little baby bird's, or an infant rooting towards its mother's breast. She was deemed terminal over 2 years ago, and hospice says she must continue to be spoon-fed until she forgets how to swallow. They can't predict when that will occur. Her daughter is filled with despair and anguish, but it was too late for me to be able to do anything to help this daughter or her mother, because she had lost the ability to make decisions about whether or not she wanted to be hand-fed. So further West Coast developments. In 2017, End of Life Washington developed their instructions for oral feeding and drinking. The form stated that when dementia is, quote, advanced, I don't know what that means exactly, oral feeding is to be limited to comfort focused. Assisted feedings are provided only while the patient seems to enjoy or willingly participates in being fed. I can tell you that this directive was received with much enthusiasm in Washington State. In New York, we thought we should go further, and we could go further, based on the needs and requests of our patients who had been newly diagnosed with dementia and their families. Some of those individuals wanted more options than limiting oral intake to comfort-focused feeding. Based on the West Coast judicial rulings and clinically vague language in some of the other dementia directives we saw, we wanted our directive to clearly indicate when the option to limit oral intake would be imposed, by whom, and how much to limit oral feedings. So, the End-of-Life Dementia Directive has 2 purposes. The first is to document the patient's wishes about limiting assisted oral feeding if and when dementia becomes advanced. The second is to ensure that the appointed healthcare agent is empowered to implement those choices when the patient suffers from advanced dementia. So clearly, the patient has to have an informed and willing healthcare agent, or this goes nowhere. This directive does not replace but augments other completed directives or instructions, like a MOLST, or again, the healthcare agent, the healthcare proxy form. It includes instructions about when to begin limiting oral intake. So we have incorporated clinical criteria for implementing this dementia directive. The healthcare agent consults with the primary care physician, and together they agree that the patient is in an advanced stage of dementia. Usually that stage is 6 or 7 of the FAST scale. And I always encourage patients with an early stage of dementia to have a look at that dementia FAST scale and see what's important to them and how does it reflect their values and concerns about how they want to die. And as I said before, that 6 to 7 FAST scale includes inability to speak comprehensively, ambulate, recognize family, or be continent and smile. And the patient must be unable to make healthcare decisions. And third, they must be unable to feed themselves. So they're dependent upon somebody else to provide food and fluid if they are to continue on living in this state of advanced dementia. So in our dementia directive, there are 2 options to limit assisted oral feeding when the dementia becomes advanced. Now, this is completed, as I say, while the patient still has decision-making capacity in an early stage of dementia. So the first option, option A, is the refusal of all life-prolonging measures, including cardiopulmonary resuscitation. That's, chest compressions, being connected to a ventilator and artificial respiration. It also refuses all nutrition and hydration, whether provided medically or by assisted oral feeding. And specifically in this option A, it refuses all oral feeding even if the patient reflexively opens their mouth when a spoon touches the corner of the mouth. So that doesn't mean you've changed your mind and you want to be fed now. It's a reflex and you're saying, ignore that. Furthermore, when that is implemented, the request is that they will receive excellent comfort care and symptom management with palliative or hospice care once those feedings are stopped. That's important. Option B limits assisted feeding. In option B, you refuse all life-prolonging measures, including CPR, and all medically provided nutrition and hydration. That's, the tube feeding, the tubes through the abdominal wall. And it limits oral feeding to comfort focus. For example, feedings are provided only while the patient seems to enjoy or has positive anticipation about eating. They're looking around and they're licking their lips and they're happy to see the food coming. They're only given food and fluids that they seem to enjoy. And the feedings are stopped once the patient no longer appears interested or begins to cough or choke. Now, it's important to keep in mind here that there's no effort made here to balance the green glop with the brown glop in order that they don't lose weight. That doesn't matter. It's all about keeping the person comfortable, giving them stuff they seem to like for as long as they seem to enjoy it. The patient is not to be coerced or cajoled into eating, and once feedings are stopped, again, they have access to comfort measures and medications with palliative or hospice support. There are further important instructions that go along with this dementia directive. Once it is completed, it must be discussed with the primary care physician or clinician, could be a nurse practitioner or a physician assistant, the healthcare agent, family members, perhaps the family attorney, and all other stakeholders who care about the patient. It's not enough to just have the healthcare agent be in charge of this. It has to be the other family members, the other siblings, the other grandkids. Everybody needs to know about this, and there needs to be an ongoing discussion about it regularly. And you give copies of this directive to all of these folks. The patient should also make a videotape of their personal values and reasons why they have completed this directive, and give a copy of that video to everybody as well. This is particularly helpful for future caregivers who won't have the opportunity to know who this person in the bed is, and will be very, very helpful to know why they are being asked to not provide nutrition and hydration, because that's what nursing aides do to people who can't feed themselves. And the other thing that's important is to remind all of those stakeholders that the patient is trusting others to not disregard their wishes because they appear comfortable or seem to have an adequate quality of life. In other words, the patient has already decided what an adequate quality of life is, and they have made their instructions clear in their dementia directive. Now, there are also long-term care considerations. As dementia becomes advanced, long-term care placement often becomes necessary. In anticipation of such transfers, I always recommend that patients and families should explore whether the long-term care administrators will honor the dementia directive before the patient enters that facility and pays whatever it is they have to pay up front for the privilege. In-service education with long-term care, within long-term care facilities will likely be necessary, particularly among the certified nursing aides who provide most care and often know the patients best. And as I said, the video will be very important for them. I should add that we anticipate judicial review. This has not come before a judge yet, but we're hoping it'll be viewed as any other advanced directive, written directive that says these are what my wishes are, and I have been very thoughtfully considering all of the options when I made this choice. So, in summary, Voluntarily stopping eating and drinking is an available legal option to hasten death for decisionally capable persons who suffer intolerably from an incurable, progressive, or terminal disease. And as I say, they get to decide what suffering intolerably is. To be successful, there must be palliative medical oversight, plus caregiving and family and or psychosocial support, which is necessary. You can't do this by yourself. And I've had many conversations with folks who think they can do it by themselves. And I have great caution when I tell them that I don't think it's going to be successful. And that's what we want here, is a peaceful, gentle death that can occur for appropriate, well-informed patients who want to control the timing of their own death. When I say appropriate, there are lots of people that think they only have to make an intellectual decision that they're ready to die, but they haven't actually done the emotional and spiritual work that's necessary in order to actually embrace their own dying. People have been dying this way for thousands of years, for generations actually. Sometimes they did it intentionally, and sometimes it was just secondarily they lost interest in food and fluid and nobody fought with them about wanting them to eat or drink. But this takes active steps, and it takes a very determined person who will basically say, I'm done. I want nothing that's going to prolong my dying anymore, and I just want to be kept comfortable. Information about this option is available on our website, and you know what our website is, right? www.endoflifechoicesny.org. And the Dementia Directive, it can be completed by persons who have decision-making capacity and wish to limit future oral hand feeding if dementia becomes advanced. They must have an appointed healthcare agent who will advocate for them, right? This is not just completing some document. You have to have an ongoing discussion with that healthcare agent. And I suggest to many of these folks who've completed these documents, and many of them have, that it needs to be brought out every 6 months or a year, and you need to go over those instructions again to be sure that they still reflect your wishes and your long-term goals for yourself. And you know, it's a good idea to initial it and date it, indicating that you've looked at this again and this is still what you want. But as I say, you must have an appointed healthcare agent, and you must discuss this with your primary care physician or your clinicians, with family members and with caregivers. And you know, you're going to have to get caregivers who will support this choice. A lot of times people want to be able to stay at home, and so you hire caregivers, which is great, but you need to be sure that they will support this kind of choice, that this is the plan of care, and they have to be able to support that. This directive, and as I said, we recommend completing a video documenting the patient's reasons, values, and wishes for future care with regard to completing this dementia directive, this completed dementia directive. It requires thoughtful consideration and the choice of either option A or B about limiting oral feeding, and indicate when you want that choice to be implemented. Now, I think we've come to the end. I want to thank you for joining this Zoom meeting. I will look forward to answering your questions, and as Lillian has said, you can download copies of the Dementia Directive from our website. And if you have any personal questions or wish counseling, call me at 212-252-2015. And I think Lillian will tell you also that if you don't get a chance to have your questions answered today, you can always send me an email at the following: judith@endoflifechoicesny.org. So I think, Lillian, I'm turning it over to you.
Thank you, Judy. So we have received questions. Can't a healthcare agent override a poorly worded advance directive?
They're two different things. A healthcare agent speaks for the patient. And the problem is if there is also a written directive, a living will, or for example, this dementia directive, and the healthcare agent doesn't want to implement the choices that the patient has made, generally speaking, what happens is the healthcare team throws up their hands and says, you know what, we can't do this. You guys got to get on the same page here. The healthcare agent has a lot of authority in New York State. So they must be listened to as a rule unless it's clear to the treating healthcare team that they're not operating in the patient's best wishes. It's a very important thing to do, is to be sure that all of your documents say the same thing. For example, the MOST form, when you choose comfort focused, a comfort level of intervention, it says that you would want to have food and fluid offered to you. If you signed a dementia directive saying that you don't want food or fluid, or you only want comfort focused, if you don't want food or fluid, you need to scratch that out and say, I do not want to be hand fed in the ability, when I lose the ability to make decisions or feed myself. Please see my attached dementia directive. Thank you for the question.
Can a family member take the patient out of long-term care or the hospital to bring them home if the hospital or institution won't honor their request for VSED?
Yes, and I often suggest that family members do that, but they need to bring that patient home on hospice, right? So they need to make arrangements to have home hospice support in addition to hiring caregivers. So there needs to be some upstream planning. And you have to kind of be careful about your reasons for bringing your patient, your loved one home. If the long-term care administrators think that you have a plan that will facilitate the patient's hastened death, you have to be cautious about what you're divulging. I would be concerned that possibly they may feel they have to step in to keep you from doing that if they think you're going to harm the patient. So you have to be kind of sensible about the reasons that you give to them, and you just say you want to, your loved one is dying. You want them to be able to die at home with hospice care, and frankly, you have to have one of these completed directives if your intention is to limit hand feeding. Hospice, I believe, in most cases, will support a clearly completed dementia directive if it seems to be consistent with what this patient has always wanted, their long-term values and wishes. And there's a documentation that they can look to that says this is the patient, this is the video, this is what they wanted. However, in the absence of a completed dementia directive, you cannot choose to not feed somebody who will participate in being fed.
We received a few questions about the timing of VSED and dementia, specifically what if someone is interested in it, but they're in one of the earlier stages, so not at that last terminal stage. What do they need to know? So how do you know when you should start? What are some other things you should consider? And is VSED still an option in these cases?
These are very important and wise questions to ask. Some of you may have heard Tim Quill on another talk that we gave, and he mentioned a book that we have been working on together, and some of these issues are addressed in our book about stopping eating and drinking and dementia and advanced directives to stop eating and drinking. But so here's the deal. Many of the folks that call me say, I'm not going to wait till stage 6 or 7 to limit my hand feeding. I want to know what I can do right now while I still have decision-making capacity so I don't have to participate in this horrible diaper thing. And I say, well, look, you know, if you choose, you can stop eating and drinking at any time. You are an adult with decision-making capacity and with the right kind of support that I've previously discussed. Anybody can do that. The challenge is that even in those early stages, stages 1 to 3, even though you're doing fine and you can still get about and you can still maybe do some work and you can still be independent, once you start having memory loss and your ability to plan, that executive function stuff, it's very hard to follow through on a decision that you may have made. I haven't seen anybody do it yet. Doesn't mean to say that it won't happen. The challenge is taking advantage of that window of opportunity. And that means being able to make an informed choice. And decision-making capacity means that you understand the choice that you're making, you understand the alternatives to that choice, you understand the consequences of making that choice, and you can remember the choice that you've made and why you've made the choice. So while you can do that, you have the ability to make whatever choice you want to hasten your death. The trick is knowing when that window is closing. And sometimes a good psychoneurologist can help you with that. Sometimes just really wise family members can tell you that that window is closing because they can tell. It's a very hard decision to make, but if you have any questions about missing that opportunity to be in charge of your own dying, I strongly recommend that you also complete a dementia directive. In case you miss that window, you'll still have a backup plan, which may not be as good as you would like, but it's better than nothing.
Is there a specific directive that should be filled out or is available to be filled out if, like Rosemary Bowen, you do not have dementia?
If you're able to, I strongly recommend that people appoint a person to be their healthcare agent in the event that they lose the ability to participate in healthcare decision-making. So that's the New York State Healthcare Proxy. You can download it from our website. The important thing with that is that you talk to this person about what your concerns and wishes and values are. What would be a life that you don't want to live? What would be an intolerable existence? There's some very good information on the Conversation Project. I recommend people have a look at that. The website for that is fabulous. Some people say to me, well, I don't have anybody I've outlived all of my friends, or there's nobody I trust that I could. So under those circumstances, get a MOLST. Get a MOLST that you fill out with your physician or your nurse practitioner or physician's assistant. And that at least will say what your end of life values are, whether you want to be resuscitated, whether you want to go back to the hospital or not. Again, anything that documents what your wishes are is better than nothing. But I go for a healthcare proxy first because a person can participate with the healthcare team in bringing your values and your voice to the decision making. Short of that, get a MOLST or do a living will.
Are the guidelines you provided regarding the dementia directive only applicable to New York State, or is this relevant to other states as well?
VSED is legal everywhere, right? Anybody who's decisionally capable has the right to, with the right kind of support, have dominion over their body, decide what gets put into it. The dementia directive is a little bit more dicey in that it hasn't gone before a New York State judge. We think it's like any other advance directive. It ought to be honored, but it hasn't been recognized yet. I've had many people call me from all over the country, and when I talk to them on the phone, I tell them to strip out the New York stuff, check with a local lawyer in your state who's familiar with healthcare law, not your real estate lawyer, a healthcare lawyer who can advise you as to whether or not this might be accepted. I'm telling you again, it's better than nothing. The more information you put down, physicians and healthcare teams want to know what you would have wanted. You can't speak to us now. We want to know what you would have wanted.
Unfortunately, that's all the time we have. If we did not get a chance to answer your question, or if you think of a question later or have a personal question, please give us a call at 212-252-2015 or email judith@endoflifechoicesny.org. Before we wrap up, Judy, do you have any final thoughts you'd like to share?
I think these Zoom meetings are very peculiar. I wish I had you all in front of me, but I don't. So I hope you'll be in touch, and I hope that you found this helpful and useful. Thanks very much.
Thank you, Judy, for taking the time to speak with us today about VSED and for your unwavering commitment to providing critical information and support for all those who need it. And thank you to those watching for joining us today to learn about this valuable end-of-life option. Thank you again, and I hope you enjoy the rest of your day.